Thank you, Ben.
Okay.
All right.
Okay,
All
this
right.
is John Antonucci, and now we're switching gears to our support group for high risk recurrent metastatic prostate cancer. We are partially supported by Bayer Foundation Medicine, Janssen J&J, Myriad Genetics, Myovant/Sumitovant, Telix, and Blue Earth Diagnostics, for which we want to express gratitude and also mention that we're under no obligation to influence our advice or your treatment in any way by these donors. I am aware that we have one new person and a handful of people wanting to talk afterwards, so that sounds fine. For let's see. So the new person is John McCarthy. Let's see if I can find him on here. Oh, there you are. Thank you for putting your hand up. So, John, we usually start with the new people if they're comfortable talking, and then move on to a discussion of updates from our regular folks. Are you okay with that?
Oh, I'm delighted to do that. If it's okay with you, and I'd be glad to have you summarize my situation if you want, or I can do it myself. I just wanted to ask that one technical detail is that I've got my GoToMeeting running on a ThinkPad laptop, and I don't seem to see people's names. Is there a way
You
to
have to
turn
hover
off?
over. You have to hover over them to see their
Oh,
name.
you don't see them until you hover
No.
over them. Oh, yes. Okay, cool. Thank
On,
you.
on, on, on a ThinkPad. And can I just say one thing, John, before you get started?
Of
We
course.
will, after we're done with John McCarthy, we will ask you again. We've made note of the 5 hands. We will ask again after we're done with John McCarthy to if anybody new has come in and if you want time. So don't worry. It's going to be the same as normal, except we've just had to change it a little bit because of the preceding meeting. Um, so John, why don't you go ahead with our new gent?
John, how old are you?
I'm 81. Turned 81 in January.
Where do you live?
Berkeley, California.
John has a very extensive and detailed history going all the way back to 2009. So I'm going to attempt to put that into a couple of minutes presentation. And John, please feel free to fill the guys in on anything important that I've neglected. He also has some questions already. So John is an 81-year-old man from California who first had a PSA increase back in 2009. There was a little bit of a delay, and he didn't get a biopsy until 2011, where he came up with a 3+4 Gleason. He had a radical prostatectomy, and after that, salvage radiotherapy in 2011. Went undetectable for a period of several years. Had a recurrence in 2017. Had a node identified on an Axeman scan in 2019, which was his first metastasis. Had ADT went undetectable again. Had a PSMA PET in 2022, which showed what's probably a diffuse group of small metastases in the spine, as well as the lymph node metastases. Back on ADT and back undetectable again until 2022 or 2023. For the first time during the next recurrence, he got on an androgen receptor signaling inhibitor. It was Enza, but he tolerated it poorly, went to Daro, and went undetectable yet again. A period of stability followed by late 2023 transformation to small cell prostate cancer, small cell neuroendocrine prostate cancer, mostly picked up by a variety of scans, and got put on carboplast in late 23. has had a mostly good but somewhat mixed response to carboplatin, and comes to us now with a few questions. He's still with Kaiser, as he was all along. He had a consultation with Dr. Small, which informed some of his questions, such as adding immunotherapy to his regimen. He wonders about that. He wonders about whether to pursue further PET CT and FDG, PSMA PET scans, or whether that's irrelevant now that he's probably not expressing quite so much PSMA, but some of his lesions probably are. He's interested in the antibody-targeted treatment. I mentioned DLL3 in my presentation earlier, which is a site found on neuroendocrine prostate cancer cells, and Dr. Aggarwal apparently has a trial going on. I don't know if it's no, it's 446. It's a different trial than I was talking about. So he's interested in advice about his trial. He's interested in further radioligand therapy and whether he should think about alpha therapies. Would like advice about any other possible scans, such as choline, and wonders how to interpret his undetectable PSA in the environment of metastatic small cell prostate cancer, and whether to interpret that as being under control or not. Has a recent needle biopsy, which was all small cell in that location, but doesn't mean that other locations aren't still expressing PSMA or adenocarcinoma cytology. He has a palliative team already at Kaiser, which he likes a lot. I'm going to turn it over to you, John.
His Gleason is 3+5 from the paperwork.
Okay.
Way back when. That was clear, yeah, when I had the prostatectomy.
Okay. Thank you, Jeff.
You did an outstanding job of summarizing, John, Dr. John.
Thank you.
Yeah, I think that does it very well. And I'm the one other thing I would add is that I am scheduled to have a video visit with Dr. Harstark next week, and then Dr. Aggarwal over in person at UCSF Mission Bay the following week. So I'm trying to kind of get my and I'm meeting with my current oncologist, Dr. Eldridge, next week as well. So I have these various questions and would love to get input on these questions or anything else. The main thing is that having uh, uh, having my metastatic turned into, at least in part, the small cell cancer has really up the ante, because it's a much more aggressive and usually fatal diagnosis. But there do seem to be some possibilities here that I'm hoping to pursue. I have 2 more cycles of carboplatin etoposide, um, unless the next scan shows that that's not doing its job, or my white cell count doesn't come back up sufficiently to support doing that.
How's the white cell count now?
Well, right now it's probably way down. I have been under the threshold, um, and I'd have to look up what it is.
Okay,
Both the white and reds are way down,
okay, quite low.
but the I think the one that they looked at the Kaiser is the white cell neutrophil, I believe,
Yeah,
and I think that their cutoff is what 137 or 37 be a number that's around that
no, I would think neutrophils would have a higher number than that as a
than
cutoff.
137.
Yeah. Len, can you
Okay,
contribute?
I can look
Yeah.
that up pretty quickly.
I think it'd be,
Absolute neutrophils. You may be talking about the absolute neutrophils, and that usually is, you hit 1, 1.5, 1.2. Less than 1 is, critical, and and that means 1,000 when I say 1.
oh, did you mean thousands, John?
I'm just looking it up now. I might as well be. It won't take too long. Let's see. My testing, blood test results. Blood test results. Do. Test results. Okay.
So let
Here
me
we go. White blood cell count is 3.9.
It's pretty good.
Um, and the differential, the neutrophils, uh, normal range 1.8 to 7.9. Mine was a 2.6, but that was just before I got the last infusion, and I guess
Plus carboplatin.
that well, I believe what's happened is this particular carboplatin etoposide uh, cycle is ideally every 21 days. Um,
Okay.
but I haven't managed to get up to that 1.8 within the 3 weeks. The first time I had to wait a week. Second time I waited 2 weeks.
So
Third time I waited.
you're not in any immediate danger from extremely low WBC right now. And
Yeah.
what they do, they just, if your RBC or WBC is too low, they just give it a little recovery time. Let's address some of your
Exactly.
questions. They're very,
Thank you.
very interesting, advanced kind of questions. What would you like to bring up first?
Well, let me just go in that order. Dr. Small recommended a couple of things. One was possibly adding uh, one or both of these immunotherapy drugs, which I can't pronounce very well. You do better than that than I, Dr. John.
Well, you
Your
have two, somebody else? Okay,
yeah let me jump in here and maybe just give this a little bit of direction.
okay,
Um,
Rick.
so I'm pretty familiar with all of these doctors, and of course, Dr. Small is sort of a patriarch figure. To be honest, he wouldn't have been my first choice as the starting point at UCSF. My choice would have been Dr. Aggarwal, who you're going to be seeing very soon, and I think probably Dr. Hartstadt would agree with that. Dr. Hartstadt's worked with both of these folks, and she knows them very well. Um, the reason I tend towards, other than for personal reasons, the reason I tend towards Rahul is because he's probably one of the two best doctors in the whole of the country when it comes to neuroendocrine disease. The other is Misha Beltran, who presented at GU ASCO and whose presentation we just discussed in the previous session. And I'm going to go back to John. John, if you could maybe pull up that Misha Beltran abstract, I think it would be helpful to have it. Now,
I did read her abstract, and thank you very much for sending that
yeah,
on.
and and
That
and it's a very encouraging abstract. Now, that trial, it may not be the one John was looking at, but that trial for sure is being run at UCSF. That DLL3 trial is being run. The thing is that Rahul, who knows us well and knows me well, but Dr. Rahul has other trials too. And
yes,
so rather than getting too much into what's the right discussion, what's the right treatment with us, or even with respect, listening to Dr. Small, I would be listening to Dr. Aggarwal. And we
okay,
can't give you advice, medical advice, but we can tell you who we think can give you the best opinion. And
no,
my money comes down very strongly on Dr. Aggarwal. If he thinks that you're a great candidate for that new DLL3 treatment, then he will probably be able to get you into the trial. That
hmm
treatment, I think, John, didn't they treat 18 people? Was that it? Do you have it in front of you?
Dr. Agarwal is on the list of authors of the thing that I presented, so it could be him. The number of people so far on this study was 66, of which 10 had prostate cancer. And this is
Right,
an interim report. The study is ongoing.
right. And how many of people in that and let us just explain something. This is a study about on neuroendocrine. Neuroendocrine disease can come up in many different types of cancer. That's why there were only 10 who had prostate cancer. Now, of those 66, how many exhibited DLL3, John?
Well, of the 10 prostate cancers, all of them did. Of the entire
Okay.
group, it wasn't 100%. But for
It
our
wasn't.
purposes in this group, you can count on DLL3 being present on your cells.
And what was the response was very high, was it not?
Yeah, now this is mostly a phase 1 trial, so they're mostly doing dose escalations, but they did do a little bit of outcome, and the outcome was well tolerated, and there was a very good response. There was a fair number of people that had the cytokine release syndrome, which troubled me a little bit, but
yeah, I
uh,
wondered about that. Uh, but it seems like that was just on the initial high dose from the way I read it.
yeah, if it's on initial, then it's called infusion cytokine syndrome or cytokine storm, and different than the delayed type. And they said that the worst ones were category 3 side effects. So no, I mean nobody got desperately ill. What category side effects do you have to be to get hospitalized, Ben? Do you remember, or Len?
I think it's 4 or 5, isn't it?
Is it 4 or something like that? Yeah. So apparently nobody got hospitalized for it.
For the benefit of the people who are here, who are listening in, um, think of DLL3 as PSMA.
Yeah.
It's a protein that's expressed on the cell, and it's something that we've known about for a while. In fact, when Herb, God rest his soul, was pretty sick, we were trying very hard to get him to do a DLL3, and then because I had in mind that we could get him into a trial, but it just didn't happen. But this particular drug, I think, is a chemotherapy type of drug that is targeted at the DLL3, but there's also they're also talking about linking it with a radionuclide like a lutetium or maybe an alpha an actinium-225. And so it would just hone in, the medicine would hone in on these cells that express DLL3, which in most cases are the small, are these neuroendocrine cells or these morph cells. I mean, we call John's disease neuroendocrine. In fact, it's not strictly neuroendocrine. The cells look like they're neuroendocrine. They behave that like they're neuroendocrine, but they didn't start out life as neuroendocrine. They started out life as something else, and they changed. Now, the experts like Dr. Misha, who treats Ben, and Dr. Aggarwal and Dr. Rahul are real experts on what the best type of therapy is, and they know what's coming down the line, and they know where the trials are starting up. And that's why I feel very good had you not have said so, I would have said, in fact, when I started reading your thing and I saw, oh, you're seeing small, my first line was, no, we got to get him over to Rahul. And then I read further down and I saw, oh, great, he's
Yeah,
going to see Rahul, right?
yeah.
And you'll love Rahul. He's a very different personality to Dr. Small. He's warm, he's compassionate. Um, he doesn't, he's not on a pedestal, okay? And you can talk
I've
to him.
heard really good things. There are several other folks in my other metastatic prostate cancer group who have been seeing him. That's
Yeah,
sounds like he's a
yeah,
good guy, and I'm delighted to hear that
yeah. No,
reinforced.
you will. He's really lovely. He really is. And so for that matter is Dr. Misha. She's terrific
Mhm.
too. Now, um, one thing that we've learned, and I think this is really important for you, and I think it's a discussion that you must have with Dr. Agarwal and review with Dr. Andrea, but definitely with Dr. Agarwal, is that the window for treatment for neuroendocrine is very, very short.
Hmm.
This was told to me by Dr. Munster, who you can quote. Dr. Munster is the co-director of the UCSF BRCA Institute. And she's actually a breast cancer doc, but she has a lot of experience in pancreatic and in neuroendocrine disease. And we talked about this extensively when Herb was sick. So whatever it is that they're going to do, they have a short time window to do it. And the fact that they started you on the carbo and etoposide is really good because they're responding to that short window.
Yes.
And I commend them for doing that. The question for Dr. Agarwal is, how long is that window going to be open? Should I finish my carbo and etoposide? Should I
Right.
switch horses right now? Do you think I can get into the DLL3? I'd have to look at the DLL3 trial and see if there's an exclusion. If you've done carboplatin etoposide recently, there may be an exclusion on that because they
Hmm.
want to keep it clean. At the same time, you may be able to finish it, and you may be able to follow up with it.
Hmm.
So these are the sorts of questions I'd be driving at him, and then come back and tell us what he says.
Yeah.
Um,
No, I think that sounds really good. Let me just because other people have some things to ask. Let me pop down to a couple of these other questions. Another thing Dr. Small pointed out was that although I s- seem to be my PSA is undetectable, or at least undetectable at the pretty gross level, under point one. Um, that uh, sometimes this neuroendocrine can also express PMSA. And so um, this actually touches two of my questions. If my PSA is undetectable, my suspicion is that doesn't necessarily mean that the regular garden variety metastatic prostate cancer is completely under control. And on the other hand, but maybe it is. But the other thing Dr. Small said was that sometimes this small cell cancer can express PSMA, and that's why he strongly recommended my getting a PSMA PET scan along with, at the same time, an FDG PET CT scan to see if indeed there's some that's expressing the PSMA, then I could be a candidate for the regular Pluvicto kind of radionuclide ligand kind of
Yeah, I
treatment.
mean, I think that's a very good approach. First of all, well, a couple of things. One is very often we don't expect neuroendocrine small cell cancer to express much PSMA anyway, PSA
Hmm.
anyway. Okay,
Hmm.
so they're low PSA expressors. Also, they they are now. I'm going to have to defer to Ben or to Len because we've actually looked this up in the past. Um, I don't think they express much PSMA. Once they're a pure neuroendocrine, I don't think they express very much PSMA, if at all. But that's a
Well,
question
that
again.
was that was what I think that Dr. Small said, that that's the case in most cases, but it's not
Right,
100%.
right. So there's no harm in doing a PSMA scan. I mean, um, they would have you do a DLL3 scan because just like with PSMA, there's a scan and then there's a therapeutic. So
Uh-huh. Yeah.
they would have you do the DLL3 scan to see what's expressing DLL3 before
Right.
you did any treatment.
Yes.
There's
Yeah.
also
Yeah. In
something
fact, that's
called
what he said, they do. I guess there's first of all a blood test, stain, to look at the DLL3, and and then a scan.
right, and there's another scan as well. And there was a poster on this. I think that one of the guys might have raised. Dotatate um, is another protein that's expressed in neuroendocrine like small cell cancer. And so, if they were to do a dotatate scan, I think it's called Spotlight. I think the name of the scan is Spotlight. But if they were to do a dotatate scan, they'd see the same thing. But I think, yeah, there's no harm in doing the scans and seeing what expresses PSMA, what expresses DLL3 or dotatate, and what doesn't express any of it.
Right.
Um, and I think what we'd expect to see is probably that DLL3 or dotatate showing up and matching what we saw on the FDG scan that wasn't expressing PSMA. But
Right. Well, as I understand it, the FDG scan is just really showing you metabolic activity. It's
right, correct.
not particularly
Not
one of these
specific.
ones that's attached to a molecule.
Right. Right, but if we know what's showing PSMA and we know where the metabolic activity is and they don't match
Exactly.
up, that tells
Right.
us that
That's
you've
the
got
thing that Small was trying to get at. Yeah.
right. And that was again, you weren't here, I don't think, for our presentation, but we had two slides talking about concordance, and
Ah,
we
okay.
and whilst we're one of the slides said, well, it may not be that important. I personally am all behind concordance because it's an early indicator of disease, of prostate cancer that's misbehaving and acting up like small cell or neuroendocrine. And what we've learned is the sooner we know that, the better, the more chance we have, and so more power to your team at Kaiser that they spotted this early and they've gotten you onto a protocol for it early, and that's fantastic.
Is there anybody else among the group who've had experience with small cell or that who could help speak to my condition?
Yeah. Well, there's a couple of people who I'm looking at right here who I suspect may be candidates, but I can sort of look across, and by and large, I don't think there's anybody who knows for sure they are. But if anybody is, please put your hand up if you think you might fall into the category where you have morphing disease, small cell, neuroendocrine like. But we've had people in the past who have.
Yeah.
Yes.
There are a couple of other guys in our the Walnut Creek group who do. So I've gotten some good feedback from them, and I think at least one of them is saying heart start, and the other is going down to
Stanford?
Schultz.
Oh, Schultz.
Yeah.
Well, I got to tell you, you're with the best guy that's out there, and I think Dr. Andrea will tell you exactly the same thing.
Mm-hmm.
I don't think there's anybody in the country who beats Dr. Aggarwal. I think Dr.
I
Beltran
hope
is on the
so.
same. No,
We'll
I
see.
mean Dr. Beltran's on the same level,
Okay.
but
Yeah.
I think both of them understand small cell neuroendocrine better than anybody. I mean,
Yeah.
Dr. Aggarwal in 2015, he gave a presentation with Dr. Small, and he reported this small cell disease. And he did that at UCSF on their prostate cancer education day. And we'd known about it before, but they were the first people to really report it. And it came out of the slides that they were developing from the prostate cancer dream team. And I've got that I've got that bookmarked here. But he's really been focused full time on this small cell neuroendocrine. Not that Dr. Small hasn't been, but not to the same extent
Oh,
that
exactly.
Dr.
Yeah.
Aggarwal has.
Yeah. I'm sold. And I definitely I'm sold on Dr. Hartstark that I think that given this development into small cell, that she's my best bet within Kaiser.
Oh, for sure, absolutely. And she can pick up the phone to Rahul, and he'll pick it up at the other end. And
Exactly.
you know,
Exactly. Yeah. Yeah.
and
Yeah.
let me tell you, it's going to be easier for her to get Rahul on the phone than it is to get Eric on the phone.
Oh, yes. Well, and maybe even to get Nisha on the phone.
Misha's pretty good.
Yeah.
Misha's pretty good, but yes. Anyway, back to you, John. Sorry, back to you.
No, I think thanks a lot for jumping in, Rick, and I appreciate those sort of distilling the big picture. And I guess the other thing is, what about this doublet therapy, either in conjunction with the DLL3 or in conjunction with my current carboplatin? Either of those immunotherapy drugs that any of you guys have heard of. There's the durvalumab and atezolizumab.
I don't think
They
any
were
of us in this group have been on
yeah,
either of those uh,
trials.
antibodies.
Yeah. I
Anybody?
think
Some from
no.
any studies? No.
Well,
We
they have been studied in prostate cancer. Again, Ben may know better than I do, but and I don't know if they're sensitive to MSI high or not, and tumor burden. But again, um, we don't have that experience, and I
Yeah,
think you can
yeah,
safely defer to Rahul on that.
yeah.
Jim Marshall, you've had your hand up for a while. What do you got in mind?
Yes, I'm curious what kind of mutations have you had, okay, at the start and then along the way?
Um, I assume you're addressing me, and it what happened was, uh, as far as we know, I just had garden variety metastatic prostate cancer, as indicated in various places around my body. But then they noticed back in September and October that there was one of those lymph nodes that looked like it was getting larger. And so that's when my uh, oncologist said, let's see if we can get a interventional radiologist to get a needle biopsy on that. It's in a little bit tricky place. It's up near the aorta, but if they can do it, that'll be a good thing. I think that was one of the ones that actually had shown up way back when we did the Axiom scan um, several years ago. And so the guy was able to actually get a needle biopsy, and the Kaiser pathology lab, and now confirmed by the his Dr. Small's group's pathologist, who's seen hundreds, if not thousands, of these small cell uh, cancers. They got my slides from Kaiser, and they confirmed that it was all small cell. It wasn't even a mixture, and that seemed to surprise people on both sides. So
Jim,
it
Jim was asking about genetic testing. Any of that?
yes, I did have genetic testing, both of my genes, and I'm don't have any of the ones that would indicate that would impact treatment, like BRCA. And the tumor itself does not seem to have some of the markers that would have suggested other therapies.
Mm-hmm. Thank you. Other questions for John or ideas? You think you might come back, John?
I probably will try to. I'm not one of these guys who is making his life going to every metastatic prostate cancer group. Um, I'm thankful that there are some guys who are doing that, and I can tune in on what they're hearing. But I will certainly come back after I confer with all three uh, doctors over the next couple of weeks. So, is there a particular whatever it is, first or third or second or fourth, that
It's
would
the
be
first. It's the first and third Mondays of the month at
right?
at let's see, you're in California, so
I've,
5
I've got it.
p.m.
I've got all that written down. I was just asking, probably Rick, whether are any of those any better than any others for me to
No,
report?
They're
no,
Okay.
all the same.
we just want you back to here because what we
Yeah,
learn from you, we can pass on to others, and that's
absolutely.
really. Plus, we would love to hear how you respond to the doctors because that's also very, very important. We may think a doctor's great, and you went in and you didn't
Right.
strike a chord
Yeah.
with them, and that's important to us too.
Yeah.
But we're
Absolutely.
very we thank you for well, thanks Jeff Marchi for bringing you in, and we're delighted to have you, and tell your guys in the Walnut Creek group that
Yeah,
I know that Walnut Creek group a little bit, and they're all very welcome to attend as well.
thank you very much. And I meant to thank Jeff first off because he was the one really responsible for bringing me to you, and I'm going to be eternally grateful for that.
Thanks,
Okay.
Jeff. And I think I'll get in the last word, which is don't waste any time, despite your PSA level being so low.
Oh no, I know. Actually, when I first got the diagnosis of small cell, Dr. Eldridge I said, I really want to know the the bad news. Give me the prognosis. And she said, well, the average is 6 months to a year. So I was thus notified, and I'm all too well aware of the short window. I think I'm
And that
already
just remember
doing well on that.
that's not carved in stone. We have seen a
Oh,
million
exactly.
people. So
Yes.
I've got about 5 people now that I know could use some time. If you have anybody else wants some time, put up your hand. And I'm going to start with Joel. Thanks, Bill.
Yes, thank you, Dr. John. I'm going to start in the middle of my situation with Dr. E and with her giving me a PSMA PET and a whole body MRI last August. And then she asked me for an FDG, and I went to the Veterans Administration and had that done to see if it was concordant with my PSMA PET. And I still don't know the answer to that, by the way, because of problems in Dr. E's office in getting that CD on her computer. But anyway,
It's been months now, Joel,
I
right?
know, I understand. They've had the
Okay.
CD for at least 4 months, if not 5 months.
Okay.
So anyway, but in the meantime, I went to my local oncologist and had them put it on the my chart system, and she has it now on her computer. And basically, it reported on mediastinum lymph nodes, which my radiation oncologist didn't think much of it. Thought it was air pollution driven. So anyway, but that's not my point. My point is that um, the FDG reported also a liver cyst, and the Veterans Administration suggested that they give me an ultrasound for my liver cyst, and I did do that about 6 weeks ago. And at the time they did the ultrasound, I had some pain in my liver and gallbladder, and they said my gallbladder was extended, my liver was sort of swollen up a bit. I didn't know what that was from. They didn't know what that was from, but there was nothing. They just found a second cyst on my liver, and they weren't concerned about it. So then I am going to take another FDG 2 days from now back at the VA because I just took a PSMA and a whole body MRI again with Dr. E in Houston last week. So the pain in my liver and gallbladder continued. Not maybe a 1 or a 2 chronic pain. Sometimes it totally went away. So I started doing some research, and I found out that not only does Orgovyx and darolutamide, which I'm on, goes through the liver. Of course, I was on Mounjaro also at the time, and that also goes through the liver. And I was taking Tylenol to relieve the liver and gallbladder pain. And even though I also was trying to take or eat better food so that the liver and the Tylenol and the gallbladder didn't have to work so hard. So I found out by researching that on the internet that liver has to totally digest the Tylenol, but if I take Aleve does not go through the liver; it goes through the kidneys. And so if your kidney stats are good, then it should not be a problem. So I switched 2 days ago, and this is very, very new, to just Aleve, and the pain went away. I think, I'm just guessing here, being my own doctor, I think that the liver was too heavily tasked with all the drugs I'm taking, and the Tylenol just exacerbated the problem. Whether or not that's accurate, I have no idea. But I am taking, so it led me to seek out, we have an endocrinologist who's going to come to my prostate cancer group to lecture in May. So I was doing some research on endocrinologists because I've never been to one. And they said, well, it's the study of hormones. An endocrinologist is an expert at hormones, and especially people with diabetes. And most people with diabetes see an endocrinologist. So I said, okay, so let me call one. So I found out that I found a 47-year experience endocrinologist, called them up yesterday. They said, okay, we can give you an appointment next December for a telemedicine visit.
Wow.
And I says, well, so then I got another referral from one of the guys in my prostate cancer support group of a nurse, and the nurse happened to be in the same organization, Innova endocrinology group. And the nurse can see me in August. So I haven't made an appointment yet because I was trying to find somebody, but between the Mounjaro and the hypothyroidism that I've had for 20 plus years and the prostate cancer meds, all these things deal with hormones. I figured endocrinology might be the perfect doctor for me to see. So I don't know if I'm right about that either, but that's just an attempt on my part to get an endocrinologist assigned to my case. So that's basically where I am. I'll report next week as to what my FDG said, if it's in accordance with the PSMAs of the last two PSMAs and FDG of the past. This time I'm going to take, instead of giving the CD to Dr. E, I'm going to give it to my radiation oncologist here locally in Fairfax, Virginia, and I'm going to have them put it on my chart so Dr. He has access to it immediately. So that's where I am. But I guess a question for anybody is: anybody had a liver issue with Tylenol before?
Joel, whether or not anybody in this particular group has had a liver issue with Tylenol, I can tell you that thousands and thousands of people have had liver issues with Tylenol.
Okay.
So I think your experiment is a great one.
Okay.
Joel, do you drink alcohol at all?
No, I used to drink maybe a glass or two of wine per month before I started my Orgovyx and darolutamide. I stopped drinking altogether because I don't feel as good when I'm drinking wine. And I never drank alcohol per se. I only drank wine and an occasional beer. But no, I do not drink at all anymore.
Okay, because you may have heard that drinking alcohol and taking Tylenol at the same time can do a number on your liver, on your kidneys.
Okay. Yeah, matter of fact, 2 blood tests ago last November, my kidney ALT and AST was down. Dr. E questioned it, but it turned out to be dehydration when I went to Miami. I'd only been in Miami for 2 days, and I took a blood test 2 days later, and I was dehydrated, so that shot my AST and ALT down. So that's all that was. During my February test, my ALT and AST are fine.
So, Joel, I'm a little concerned with all of the different drugs you're taking, whether you're going to get yourself crossed up with an endocrinologist.
Well,
Because
yeah, go ahead.
because some of the symptoms that you're experiencing are a result of of the medicines. So what I would suggest you do is ask Dr. E whether she thinks you should see an endocrinologist, because
Okay.
she's going to understand to what extent these hormone related issues that you might be having come under the auspices of an endocrinologist, and how much might come under the auspices of an oncologist. Now, you mentioned that you are, is it hyperthyroid or hypothyroid?
Hypothyroidism. Hypothyroid.
Hypo.
Yeah, since
Okay.
1995.
Now, who treats you for that?
Oh God, the doctor's retired, but I have one of my general practitioners treating me for that with Synthroid. I've been on Synthroid for the last 25 years or so.
Well, I think, I'd go back to that I'd go back to that doc. And the other thing is maybe try and source an endocrinologist through the VA,
Yeah, I can
because
certainly do that.
I think that especially given all your situation, you might be able to get to an endocrinologist first. But I think the first thing I do is just check with your quarterback medonc whether in fact that it's going to help you, or it's just going to confuse you and confuse the situation. That's how I would read it.
Got it. And yeah, the VA is strange because sometimes you can get an appointment the day after you call. Other times you have to wait 5 months. So it varies depending on what the issue and what the equipment is they're going to use to analyze you. But I'll do that.
Anybody else have any comments or questions for Joel?
I saw a hand go up. Who was it?
Gary.
I was just going to say, Joel, if Dr. E does think an endocrinologist would be helpful, besides the VA avenue, you could also ask her if she could make a referral at Houston Methodist.
Yeah, that makes sense. Sure. Thank you. Yeah,
Okay,
I'm sure she
Joel, let
will.
us know what happens.
Sure will. Sure will, John. Appreciate it.
Mark, what's on your mind? Mark
Oh, I
Bailey's,
just
if there's two Marks. I don't know if there are today.
just quickly, everybody says it'd be good to get a new genetic testing, and I want to run this by you because Dr. Borno said that since I'm on ADT and have almost no PSA, that I don't have enough to do a circulating biopsy, that there's just nothing there.
Mm.
And so she doesn't think I can get retested. Is
Might
that
be.
right? Or
Yeah, that could be.
Yeah, I mean, if your PSA is very low and you don't have a lot of tumor burden, then we may not be able to pick up enough CTC, circulating tumor cells, to make it worthwhile. And if that's her judgment, that could be the case. What that then means is you could still do a somatic test if you've got an identifiable lesion that could be biopsied. Do you
it
have
was
any
just
idea?
the only lesion I had was on my pelvis, which they just irradiated.
Oh boy.
So
Okay. So I would say that if your PSA is low and you don't have any other observable lesions right now, you're probably going to have to wait to do a somatic test.
okay, that's what I thought she meant, but I just run it by your guys. And then the only other thing is, in the last hour, I took a call from Dr. Barno's office. I've been complaining about the extreme fatigue since I went back on Xtandi. I was on it for 3 years, and it was bad, but not real bad. And in January, I went back on Xtandi, and it's so much worse. So she just called and told me to drop it for at least a week. She said sometimes you stop it, and your body it's not there anymore. And then when you restart it, you don't have all the same side effects. I'd never heard anything like that before, but
I think the easiest solution is tell her you want darolutamide.
we're working on that.
Okay, and you just say, whatever you got to do, get me darolutamide.
Yeah,
One of the reasons they don't want to do it, these docs, is because it is more work, and it does
yeah,
involve more work. And somebody like Dr. Borno, she's only part time. It's more work. She probably doesn't have the staff, and she's trying to push you through to get it. But I gotta tell you that. We could solve this problem for you. I suspect we could solve this problem for you quickly. I have a feeling John McCarthy's going to confirm that. What's on your mind, Mr. McCarthy?
Yeah, exactly. I started out on Xtandi, and I had a horrible reaction to it, and I told uh, my aunt doc, look, I can't handle this. That's giving me vertigo and everything. She immediately, and I said, I think I should go to darolutamide because I see that doesn't cross the brain-blood barrier. And she said, fine, we'll just okay that. And I've been on it ever since. It hasn't been costing me very much through Kaiser, and I'm a happy camper. I did notice when I looked at your previous session recording that there was a lot of fans of the darolutamide.
yeah. Well, I've got to call next week with Linda McMullen, who's Dr. Barno's whatever, I don't know what it is, and I'm just going to push harder this time. So we'll see. Anyways, thanks.
Okay, Phil, you have your hand up?
I wanted to just mention to Joel, I recently had a Foundation 1 liquid CD, have a very low PSA, and what they basically said is not because of the low PSA, but because of the low, trying to think of the term, but it's um, tumor fraction. I had less than 1% tumor fraction. They weren't able to pick up much. They picked up a check 2, but nothing else. And so not very informative at all. Had it done, but I'm not sure that it has much value in that case. So just wanted to mention that to him. That was it. Well, I think it was Joel who were talking about, or whoever was just talking last. In any case, and I would like some time when we get a chance.
Yes, I do. I'm going to just continue with you now that you got the floor. Was it Mark or Joel that had the low
Mark,
PSA? Mark, okay.
Mark.
Okay, you got that, Mark? Didn't work for
Yeah.
Phil. What else do you have to bring up, Phil?
A few things. One, wanted to know if there was what the test is if they have one for small cell and neuroendocrine. Is there a test that can differentiate, and do they need tumor itself, or can they do it on a liquid basis?
Ben, could you take that question? Ben might not be still with us. Okay, anybody
Sorry.
else?
Yeah.
Well, that slide you presented, John, on DLL, delta like ligand 3, I think it is. That is the most common marker for neuroendocrine cancer. There are others, chromogranin A,
Somatostatin,
metastatin,
dotatate.
a few others, but the most prominent is DLL3.
Is it clinically available then?
Yeah, right.
That I don't know.
So it is not clinically available because we looked into it commercially. It's only available if you can get into one of these trials, which are at 8 sites throughout the country. Let me see if it's at UCLA. I don't think it is. I know it's at UCSF. So what we've suggested is to do there is a dotatate scan, which is more readily available. And we've suggested that you do a dotatate scan and see what that shows up. That's used quite frequently in neuroendocrine disease. And one of the posters did show that the dotatate, I think it was one that Len mentioned, did show that the dotatate was expressed in prostate cancer in men with prostate cancer if their disease was morphing. So one thing to do is obviously the DLL3 if you can get into the trial. Another is dotatate or somatostatin. You can also take a look at a recent PSMA scan if you have one, and compare it to a recent FDG scan and see how concordant they are. Because if you're showing a lot of activity on the FDG scan that doesn't show on the PSMA scan, that might be a clue to the fact that we need to check those non-PSMA expressing cells. And you can do what John did, which is you biopsy those cells, and then you can see visually, as they did in John McCarthy's case, that the cells have morphed.
Okay. I have
Here's
actually
a
just in the last week had both a PSMA and a FDG scan. So I'll talk to my medical
yeah,
oncologist on Friday and see what.
sounds like a good plan. There's another really interesting thing that I saw uh, recently. It's an assay that's called NEMO, the neuroendocrine detection and monitoring assay, that was reported in the March 2024 issue of Cancer Discovery, and it is a blood test actually that can be used to not only distinguish neuroendocrine, but also to estimate the amount of tumor burden for each one. It's still not available commercially, but if you look up that March 2024 Cancer Discovery issue or just search for neuroendocrine detection and monitoring, NEMO. My hope is that there's going to be something available soon.
Okay.
Hold on a sec.
Yeah,
One
could I,
sec. Phil, just
yeah,
one
could I,
sec. Phil,
could I interject something real quick?
no, just a second, Markfin.
Okay.
The test, the DLL3 is available at Cedars-Sinai. They're running that trial at Cedars-Sinai. And I'll put the contact in the chat window for you. The principal investigator is Kanya Sankar, and the admin is somebody called Garrett Cook, and I'll put it in the chat window for you. And following that, I'll also put the link to the trial. Okay.
I
Sorry, go
appreciate
ahead,
that.
Martin.
Yeah, just real quickly, one thing I would like to mention is there's been some discussion of working with Houston Methodist and Dr. E. I've been working with her, and I found she's a very good resource. I would suggest that if you're going to work with them and you don't live in Houston or you're not going to travel to Houston all the time, that you take a large dose of patience in working with her administrative staff. It's very difficult. And I spent the last almost 3 weeks just trying to get a CT scan orders to my local people and get it done. So it's just, it's partly of being remote. And so I understand that. It's partly being a patient that hasn't been with them that long, maybe, but it's just something to be aware of. And I would just take a heavy dose of patience when you are dealing with them. And I think the advice you get and some of the thoughts going forward are excellent. So that's makes it worth it, but it's just something to be aware of.
Thank you,
My
Mark.
experience.
I hadn't finished yet. I had one other thing I wanted to ask about, if you don't mind.
Go ahead.
Ben's
I didn't mean to
presentation.
interrupt.
Oh, no problem. Ben's presentation, there's a slide that dealt with overall survival based on the site of the metastasis, but I only came in on that slide, so I don't know what presentation it was part of. Is there a way to at least hone into that?
Yeah. So to answer that one quickly, we will be posting all of the slides and a recording in the next 48 hours. And so
Okay.
you'll be able to find that slide on there. There will be a link to that slide. It was a presentation that Len made, and you can reach out if you have questions, reach out to Len and ask him, len@ancan.org.
Okay. Thank you.
All
I'm
set, Phil?
yeah, I'm about to see two of my oncologists here this next week. Now that we have these scans complete, just wanted to tell you, I went through 7 docetaxel. It had a very limited impact on the cancers I have. I've
Oh,
just finished 2 um, lutetium um, treatments, and I've got the results from those just today. And I'll be discussing that with my doctors. Uh, what I found was, and I feel fortunate about this, some of the cancer responded to the lutetium, and some of it didn't. But I think I have a mixed bag cancer here, so that's part of the issue.
Okay, so that's a very important observation, Phil. You're not unusual in that we see this, and that, to me, this is how I respond to it. Indicates that yes, there may be some morphing going on, and what I would, if it were me, what I'd be pressing for is to try and identify that morphing most easily through a biopsy. But here's the big problem with a biopsy. The morphing in the neuroendocrine cancer doesn't appear across the board. With prostate cancer, what's normally the case is that if you have adenocarcinoma, the genomic profile of that cancer is the same wherever it shows up in the body, any place. But that's not true with morphing, and that's not true with neuroendocrine cancer. So you might find it in one spot, but you wouldn't find it in another spot. So the systemic approaches using this DLL3, if you were eligible and could get into the DLL3 trial at Cedars-Sinai, would give you a much better example. If not, we have to jerry-rig it with somatostatin or dotatate. And there's been some pushback on that. I mean, when Herb, God rest his soul, was in NIH, they didn't want to do the somatostatin. They didn't want to do the somatostatin scans or the dotatate scans. But now there seems to be more evidence that the dotatate scan could show something. And we know the DLL3 shows something, but the DLL3 is much more limited. So I would be pushing real hard, since that was your result, to try and get some type of dotatate or DLL3 scan to see, because if in fact that's the case, you have to do what they did with John McCarthy, and they've got to schedule you for treatment as quickly as possible. And the DLL3 this DLL3 trial at for what is it called? The drug is
HPN 328.
HPN 328. Thank you. The drug is HPN 328. Would be a great fit for you.
Okay. I'll see if I qualify for the trial. That would be the first. And they're close to me, so I can easily get to Cedars. It's not a problem. And I'll see if I qualify. Thank you for your insight.
Stephen, you're up next.
Thank you. I will be Medicare eligible in May, and will need to get a Part D plan. And was curious if there is one Part D plan that any of you have had better experience with than any other. Is there one that's more favorable to prostate cancer patients? Thank you.
Did you say Part D or Part B?
D is in dog.
Okay, D.
Yes.
Anybody have a Medicare Part D plan that they've been especially happy with or especially hate?
I've got a Part D plan. The only drug that was affordable was Casodex, bicalutamide. You get beyond that, and they're very expensive for most Part D plans.
Okay.
I had whatever I've got. I forgot that if it's an N or something. It's not too expensive, but I got it back before I had prostate cancer, and I decided to save a little money by not getting the one that pays the co-pays when you go see a doctor. I would have done better to get the other one because I see so many doctors. I pay a lot of $20 per visit ones, so I would get one that covers that.
You taking first generation hormone therapy or second generation hormone therapies?
Me?
The one who asked the question, are you talking about first generation or second generation hormone therapies?
Okay, so my hormone therapy is covered by Part B, and I've confirmed that with.
Well, that's injections.
Yes.
Okay, Part D would cover any pills like Casodex or the other second generation hormone therapies. That's different. Part B and Part D cover different types of things.
That is correct. And I guess I'm just looking long term here, because right now the only prescribed medicine I take is hydrochlorothiazide.
Okay.
Yes,
So
that's high blood pressure.
Yes, exactly right.
think,
Exactly right. Yep.
Steve,
Yes,
I
sir.
think you have to look at this maybe slightly differently. Unfortunately, with most of the plans, whether it's an Advantage plan that includes the Part D or a separate Part D plan, the cancer drugs are going to be really expensive. You're not going to get away from that. Now, you may be eligible for subsidies, and some of the guys in this group have gotten subsidies and quite successfully. But the way that I look at it is, what is my maximum out of pocket going to be? Because that's what I've got to be prepared to pay if I need cancer drugs. I can't be thinking of it in terms of, oh, my plan's going to pay for most of it. No, it's probably going to cost me $500 for the first month, $500 for the second month, and then maybe it's going to go down after that, depending on what my maximum out of pocket is. Are you military, Steve?
No, sir, I am not.
Okay. So all of this is going to change. And I can't give you details because I don't understand it well enough right now, but we're trying to get details and we'll circulate them. But the IRA, the IRA, the Inflation Reduction Act the IRA is changing how the donut hole is going to work. And payers are going to be required to pick up more in that donut hole. So what is the donut hole? In most plans, you are required to pay a certain amount on these drug policies, usually somewhere between about 4,000 and 8,000 yourself. And after that, there's a period of time when you don't pay anything, and then after that you pay a very small amount. And the period of time you don't pay anything is called the donut hole, and then after that you pay a very small amount. What is happening is they're shrinking, or they're expanding the donut hole. So they're shrinking how much you have to pay out of pocket, and you get subsidized sooner, and they're putting that onto the payers. We don't know what the payers are going to do and how they're going to respond, and they may make more drugs less available. I just signed something, a letter to CMS this morning, signing off on trying to keep CMS and the payers in line. But the bottom line is the Inflation Reduction Act tried to help people on Medicare with their drug costs, and they're phasing this in over the next 2 to 3 years. Nobody really knows exactly how it's going to work, but hopefully at the end of the day, you'll be paying less. So you have to factor all that thing in. My recommendation to you and to anybody else who's starting out for the first time is get yourself a Medicare insurance broker, somebody who specializes in Medicare. It won't cost you anything. They understand these issues. They'll understand this IRA thing even better, and they'll be able to explain to you, and they will be as good as anybody. There's not much point in asking a question, what Part D plan do you like, in a forum like this, because we're national, sometimes international. And all of these plans are state plans. So a Part D plan that's offered by Blue Cross Blue Shield in a certain category in Michigan, or what? No, you're down south somewhere, Louisiana,
Mississippi.
Mississippi. What they offer you in Mississippi is not going to be the same as what they might offer Steve Rue in Michigan, or whoever it was that or Brian in Ohio. Okay, so find yourself a good broker and review with your broker, and also bear in mind things are changing big time. It's all in a big state of flux right now.
There's one really important thing. The $8,000 is not what you have to pay. It is a combination of what you pay and your provider has paid. And I found, like last year, I only had to pay about $2,500 before I hit the 8,000 limit. And I was in the donut hole for one more payment of $256, and it went down to $12 every month. So it's not just what you pay, it's also your provider.
Okay, thank you all very much.
I got a couple of hands up, then I'm going to go on to Bill Lee. First of all is John.
John McCarthy, that is.
Could you unmute yourself, John McCarthy?
I think that just was still up. I didn't realize that it automatically didn't go
Okay,
down.
I'll take care of clearing it.
I'll
Joel,
take it
is yours old also?
Yeah, no, I was just wanting to comment on the comment made by a member here about Dr. E's staff being an out-of-towner from Houston. He said it eloquently, and I totally agree with him 100%. And she's had to fire a lot of people in the past year. And I found out a lot about her staff through the pharmacist at Houston Methodist just because she knows them all, and I've never ordered a pill from that pharmacist, but she helped me get darolutamide and Orgovyx out of the system, even though she didn't it had nothing to do with her pharmacy. She just knew Dr. E staff. The point is that I've had to put in sometimes a couple hours of work each day for 2 or 3 weeks before I go to Houston, just because the staff is incapable of getting the job done. So I just wanted to say I agree with what he said.
And Don, what did you have to bring up?
Yeah, I want to bring up about Rick's comment about going to a broker for Medicare advice. Be real careful, because the biggest payout the brokers get is when they put you into an Advantage plan. They virtually get nothing. They get nothing if you go to A and B. I tell you, I've looked at this. I've looked at this carefully. Uh, Definitely get an A and B plan with a SUP. It's going to cost you more money out of pocket, but boy, when you're a cancer patient, it's remarkable. I look at the bills I've run off over the course of the last this journey for 2 years, and the billing has been over $450,000, and because I have SUP F, I've paid nothing, not 10 cents. And the advantage, the huge thing about being on traditional Medicare A and B is that you choose where you go when you want to go. You don't have to go through a gatekeeper that you would get with an Advantage plan. Uh, as far as the cost of drugs, next year, 2025, maximum out of pocket is going to be $2,000. It's a huge savings.
So I'll respond to some of that. I agree with Don to a certain extent, but not totally. If you've got a good broker, they're not going to necessarily push you into a Medicare plan. I don't know for a fact that they don't get any money from the other plans. I suspect they do. But they like to put you in, they do prefer to put you into an Advantage plan. But a good broker is going to talk to you about what best suits you. I mean, if you haven't watched it, please watch the webinar that we put on at the end of October. You can Google triage cancer. The broker who was in there is actually my broker. He was very honest and very straightforward, and he talked about the different plans. I will also tell you that depending on where you live, the G plan, which is now the best plan, the F and G, but I think they dropped F, and I think it's now just the G plan is the only one available, can be expensive. It can be $400 or $500 a month. So you finish up paying $6,000 or $7,000 for your F plan. And what you then have to do is compare that to what an Advantage plan might cost you, which could be very little, and then compare that to what your maximum out of pocket is on the Advantage plan, which is what I did. And it turned out that on my Advantage plan, I was saving myself paying about $5,000 a year, and I was hanging out for about $3,000 a year. So if I needed treatment, God forbid I needed treatment, it's probably going to cost me $8,000 out of pocket and then very little after that on my Advantage plan, versus being sure that I was out of pocket about $4,000 or $5,000 a year. So these are it's not as simple. And some of the Advantage plans can be quite good depending on where you live. So you have to look at the Advantage plans and see which doctors, hopefully not which doctors, what doctors they cover, and go from there. But this is why I encourage you to talk to an honest, good Medicare broker who has your interests at heart and not their interests at heart, and talk to your buddies and ask them. And our guy, Kim Umphreys, has said he'll talk to anybody anywhere in the country. He only writes in 11 states. I don't know if he writes in Mississippi or not. but he said he's always there to talk to you. So, use that offer.
Cliff, you want to join in on this conversation?
I just wanted to bring in my update, basically. I went to my oncologist today.
Hold on a minute. Hold on a minute, Cliff. We have Bill Lee to come, who wants time for himself, and then we'll put you in after Bill Lee.
Well,
Thanks.
I got Bill and Steve, and then I'll get
Okay,
to Cliff.
I'll wait. I'll wait. Thanks.
Thank you,
No,
Cliff.
I'm good, and thank you all very much for your input.
You're welcome. Bill, what you got?
Quick update in case those that don't know my situation. So I'll just run real quick through it. 2020 had a PSA of 66.11. Ended up having a radical prostatectomy. Gleason 7, 4+3. Had positive margins in the bladder neck. Never went to non-existent with PSA. March of 22, PSA went to 0.64. Ended up with 40 sessions of radiation. Then June of 2023, PSA went to 0.99. December of 2023, PSA went to 2.202. I got with Dr. Heath, Rick, and very nice. She looked at all this information and turned to her intern and said, "Here's your 1%er." And then she goes, "Oh, I've had a PSMA PET scan scheduled for February 20th, so she didn't have that before the meeting, but I'm gonna put you on Lupron, and then see if we need a second, like darolutamide or what the E one,
Enzalutamide.
enzalutamide, yes. So anyways, had the got the blood work done on February 12th when I met her. Found out why I'd been so tired. My testosterone's 174, and I'm not even on ADT yet. And then my PSA was at 3.009. So I've got a doubling speed of 4.2 months. So got the PSMA PET scan. My radiation oncologist, who's the one who ordered it, he looked at it, gave me a call that night, actually, because it came in so fast. And he goes, "What I'm looking at, Bill, your scan looks great. It looked real clear. And where they think there's an uptake, I looked at your radiation field, and it was irradiated, that whole area." So he was confused as to why something would be lighting up right now. Well, the next day, he actually got on the phone with Dr. Heath, and they both looked at it. They both looked over the report, and they found a nodule behind the bladder. He says it was hiding behind the bladder. So the radiation didn't quite get there, I guess.
Wait, a lymph node, is it, or what?
He said nodule, but I'm sure that's meaning a lymph node.
Okay. So you're now hormone.
So,
you're now
yesterday
metastatic hormone sensitive.
Yep. So I had my first shot yesterday. Lupron.
Okay. Any questions about what to do next?
I've got another appointment with her June 6th or something like that, June 4th. It's a Monday.
Okay.
June 3rd, I meet with her, and we'll discuss everything. And I mean, she did take blood for genomic testing and all that also. Get that. Couldn't remember.
And she is going to add a second line anti-androgen. Is that what you said, Bill?
Yeah, she said she wanted to take that slower though.
Okay.
To see
so again, we'd suggest, based on the experience of the men in this group, that you lean towards darolutamide.
Correct.
By the way, we had another gent attend for the first time last week. I forget his name, who is also seeing Dr. Heath and has been seeing her for a long time. Just can't remember his name. I think Jim Marshall. Jim Marshall, what was his name? The gent that you brought in last week.
God, I'm trying to remember. Drawing a blank.
Yeah,
Was it Don?
could have been,
Wasn't
yes.
wasn't
But
he here tonight?
I'll find it and I'll put it in the chat window. But he was a pretty confident guy who seemed to know quite a lot. So I'll find it and I'll try and make a connection. But first of all, it's a relief to know why your PSA's been going up.
Yep, definitely.
Secondly, you probably have very treatable disease, which is a good thing. Um, and thirdly, you're with a very good doctor now, and you can already see the difference that's making.
Yep.
And I'm assuming from what you said that you were happy with her. How was her bedside manner? And other than she's obviously smart, how was everything else about her?
Very smart, very cordial, very sweet.
Good,
Talks, stays with you as long as you need to talk, and
good,
same with her intern. The whole Carmanos group there. I mean, I've been up to the Clarkston one for radiation, but the one there in Farmington Hills is where I was going, and they've got that thing working very smooth.
fantastic. And how far was that for you to go?
It's 23 minutes, 30 minutes
Oh,
drive.
okay. So that's really
You know, up
convenient for
here in
you.
Michigan, everything's by how long it takes, not how many miles.
Okay. Well, we're glad. We're glad you found somebody good. We're glad you're in good hands, and we're glad we now know what's been going on with you.
Yep.
How are you
Have they
coping?
have they talked about a
Uh,
biopsy of that
I'm
nodule?
sorry, what?
I was wondering if they talked about a biopsy of that nodule or lymph
No,
node.
the radiation oncologist actually said he was going to consult with another radiation oncologist up in Flint because they have the proton beam machine up there, and whether it was feasible to hit that spot safely.
I'm talking about an actual biopsy where they put a needle
Right.
in it, take a sample
Yeah,
out.
they didn't say anything about that yet.
Okay. You might ask.
Yep.
I was wondering how you're coping, emotionally. You got news that
Well,
you're
I'm
static
coping
now.
fine. If the ones who saw my first presentation was this is my second cancer. I had colon cancer also in 2020,
Hmm.
and I'm net on that. So I'm in my fifth year, going in my fifth year here. We're good there. The only bad issue was on Thursday. I participated in the highly competitive event of laundry basket stair climbing. Got halfway up the stairs, and I heard a large snap pop sound in my left knee.
Oh
So
no.
I get to go see a orthopedic doctor tomorrow to see how much damage. Hopefully it'll heal on its own, but there's certain movements I can't make that doesn't send me through the roof. So
Too bad. Any other comments or questions for Bill? Is Steve Rue still here? I don't see him.
I am
Yes.
still here.
Oh, there you are. Okay,
I,
great.
I like the sound of that. I am still here.
Yeah.
Uh, well, that's a perfect segue following in with hearing from Bill. I'll be seeing Dr. Heath in 2 weeks,
Oh,
and it'll be a lot longer than a 30-minute drive. I've got about a 4-hour one-way trip to get to her. But she came well recommended. Rick had said something about maybe seeing her, and it sounds like I need to. I don't know. I honestly don't know how much I'm going to get out of that first meeting, though. I had returned this last week to my local medical oncologist with the idea that, after taking a 90-day break from Lupron, I had energy again. I was able to get up and walk, and I got a full-time job. I was feeling great. My PSA is still undetectable. The testosterone is up, I guess slightly. I'm up at somewhere around 262, I guess. I think I was in the 700s before all this started. But I had enough energy. I'm feeling a lot better. I don't feel the fatigue knocking me down daily from the Lupron. So the idea was to go see the local medical oncologist to say, okay, I'd like to continue the 18-month Lupron treatment, start it back up. And he told me there's no sense in doing that. His comment was that he does not recommend that and didn't want to follow that idea to restart. His medical notes, which I found on my portal, say that I've completed 18 months of ADT with the Lupron as of August 23, and I still can't get the calculator to cooperate with his numbers. My first Lupron shot was October 22nd, so I'm not sure how he's using an abacus or what to arrive at 18 months. So, one of the things I'm probably going to do when I see Dr. Heath is find out if I should restart the Lupron, and maybe that's not an option now, according to my local medical oncologist, that based on what he's saying, that's just not the procedure that's worthwhile, that it won't do any good, So I'm kind of curious if anyone else here has heard anything similar to that, where taking a break from ADT, I was getting every 90 days I was getting an injection, and then to stop the process for 3 months and then to go back and start it again. Has anyone else heard anything like that, where that's not a viable path, procedure to continue to
No,
follow to restart it?
not me. I mean, you're still hormone sensitive. I don't see why not. Len?
Well, Steve, you're referring specifically to a 3-month on, 3-month off protocol with the hormone therapy. Is that right?
No.
It was every 90 days, the Leuprolide injection every 90 days.
Yeah.
And along came October of 23, when I told him, look, I'm going to take a break. I don't want this shot in October, the usual time to get the injection. I'm going to wait 3 months, go through Thanksgiving, Christmas, whatever, and I'd get back to them early in 24. And they were okay with that. And so that's what I did. I went back in February, early February of 24. And now I'm hearing that that's not a process or procedure that will do any good to restart, and continue the additional months that would actually total 18 months, as opposed to whatever math he's using, new math or whatever, to arrive at that 18-month number, because I haven't had 18 months of ADT.
Yeah.
So that's one of the things I want to bring up with Dr. Heath, and when I see her in a couple of weeks, and I may not see this local medical oncologist in the future.
Have you
But
been getting regular PSA and testosterone tests during that period?
yes, prior to every injection, they would do a blood draw to check everything, and my testosterone was way low, and the PSA was undetectable, and it has remained that way ever since I had my very first ADT injections and my high dose radiations back in 22.
So
Well,
I think the issue, because I'm looking at your notes, the issue is originally they gave you Breaky plus IMRT, and they said you should do 24 months ADT, and you were having some issues. And we felt anyway that with your diagnosis and the standard of care today, that a second line anti-androgen should have been added. And the reason we wanted you to see Dr. Heath was around this second line anti-androgen. Now, the fact is that you decided after a period of time, I'm not sure how many months were you for sure on the ADT. When did you
First
get your
shot,
last?
the first shot was the first injection I had was October of 22nd,
And when
and
was the
I think
last shot?
they also had bicalutamide added to that
Right,
at the
forget
very
that for
start.
the moment. When
Okay,
was the last shot?
the last shot was August of 23.
3. So you've taken it on yourself to say, I don't want to do 24 months. I don't even want to do 18 months. I want to do 12 months. And it's working for you right now. Now, that said, with people that are a 5+4 and your sort of disease, what we've seen is you need more than 12 months. But we've had people take themselves off after 12 months. Jimmy left. Yeah, I don't know, something came
Yeah, he
up.
left. Yeah.
But Jimmy took himself off after 15 months. Other guys hung in. And what we don't know is how you're going to respond. What we do know is that ideally, to get the best results, you probably should have stayed on continuously for at least 18 months and you should have had a second drug attached to it. So your guy isn't wrong, but he's not really right either because he didn't give you the right medicine in the beginning. At the same time, you've made the decisions of where you want to go. So if the disease, God forbid the disease comes back, there's a higher chance it could and it will, then you have to say, okay, that was because I didn't want to do the time in the beginning. Now I'm going to have to do the time at the back end.
Well,
That's where you are.
I wasn't saying I didn't want to complete the entire run. I wanted a break. I just wanted to catch
That's
my
enough.
breath.
That's enough. It needs to be continuous. You can't just say I
Okay.
want a break. You need what we've seen is you need at least 18 months continuous. And if you stop after 12 months, that's your call. You can do it. And you may be one of the lucky guys who says, okay, it all came out great. Jim Ward just put his camera on. Boy, we wanted Jim Ward. Jim Ward wanted to stop after 9 months. And we lent on Jim Ward and saw it through. And he got through and he got through to the end and he did it. But he did it for testing. But he would have done, if you give half a chance, Jim Ward would have stopped after 12 months as well.
Oh my gosh, this. Well, I look. Rick's giving you solid advice, but my goodness, this thing has become almost mythical. So I will start once again, because I won't be the poster boy for somebody who didn't handle it the way that Rick's suggesting.
Too late.
I asked my doctors, how long do you think I should be on ADT? And they said, two different doctors, my GU med onc and my rad onc. And they both said 2 years. And I said, okay, let's do it. I never whined or complained about it, and I certainly never said, "Oh, gee, I want to quit this after 9 months or 12 months or 18 months." So you know what?
I'm not so sure about
Rick.
that.
Hey, man, you know what? That's a bunch of horse dookie, as they say in Texas.
Okay.
So there you go, buddy. Horse
We'll have
dookie
to.
all the way. But
Okay.
you
We'll
know
have
what?
to.
You're giving him great advice, which is,
Okay.
and I agree with it, is he needs to be on it for a minimum of 18 months. And the real point
Oh, do
here
I
is,
start again and go 18 months?
Well,
No,
I don't like to speak.
because we don't know.
yeah.
We don't know, and there's no now that you're off. That's why you'll see what Dr. Heath says. She may say, you know, I really think for the best thing you should restart, but you're in uncharted territory because we know you should hang in. And most of the guys who stop after 12 months, they stop. And then they wait and see what happens. But it's more likely that it's recur, but there's no assurance it'll recur. And maybe you were the smartest of all of us and you stopped at the right time. We don't know. But there's no evidence.
Peter is dying to get a word in here. Peter, can you contribute to this?
Yeah, taking a 3-month break gets you nothing. It's a waste of time. If it was me, and it's been me, I would go the 18 months and then stop and take 6 or 9 or a month or a year break. But take going off for 3 months and then going back on doesn't make any sense at all, because you won't feel the difference at least until 6 months, if then. So
But
just
that's what he's done,
breaking it
Peter.
up makes no difference at all.
But he's done that already. We can't wind the clock back. What would you do now? Can't turn the clock back. He's taken the 3 months.
Take 3, yes. Okay, then if you go back on, don't go back. I mean, go back on now and just finish the 18 months out, and don't.
That's what you.
Yeah, don't take 3-month breaks here and there.
No, I'm not trying to do that. I just needed 90 days to catch my breath and get back on my feet.
Yeah, I guess what I'm saying is 90 days doesn't really catch your breath with this drug. We know it's miserable. I mean, most of us have gone through it, and it's crap. I get it, but 3 months doesn't let you catch your breath. It's still in you, and your testosterone's not going to come back. Just finish out the 18 months and then take a break. That would be me.
Yeah, but would you finish out the 18 months after you'd stop for 3 months? Would you do 12 months, take a break for 3 months, and then take another shot for 3 months, Peter?
Well, it's 6 months, isn't it? He's done a year.
He's only done 6 months.
He's
had
he's
2
done
shots.
12 months. He stopped for 3 months. Now what would you do?
I'd go back and take the other 6 months to make it 18 months, and then reevaluate and take a break. Then
that's what I was trying to do.
That would be me. That would be my vote. I mean, I can't tell you what to do, but
that's what I was trying to do.
Huh? What was the original?
That's what I was trying to do. I was trying to get back on it, to finish out the last, 6 months of further treatment.
Well, that's what I would do, because you're probably not feeling great taking a 3-month break right now anyway. So what's the difference?
Yeah, I am. I'm actually feeling wonderful. After just 90 days off, I don't know.
That's amazing. Okay. Well,
that's a nice
tolerated better than most of us.
Yeah. What was your original Gleason score, Steve?
5 + 4.
5 + 4, and no mutations, right?
That's what I understood. Yes.
Okay. Yeah, let's see what the expert thinks when you get down to see her. I'm dying to hear. Because you were a 5 + 4, I would say finish to 24, but let's see what she says.
Yeah, I'm willing to take it out to 24. That was what I was trying to do, was just restart it and saying, hey, I had a wonderful vacation, the holidays, I've got my energy back, I was able to travel, I'm not taking a nap 3 times a day. Great. I can work again, and I'm feeling great. So then I went in there to say, let's start it up again. And
ask her about going on to monotherapy darolutamide in place of it.
I was going to do that.
And then I bet your energy will stay up. I've done that.
Okay.
All right, I got a guy that's been waiting for 2 hours. Cliff, I want to get to him before we run out of time. Cliff.
Thank you, John. Peter's kind of already answered my question. I've been on drug holiday since December 20th. And today was my first day back to see my GU oncologist, and my testosterone is now up to 184. My PSA is still non-detectable. And I was going to ask the question, but I'm still having hot flashes, still having all this stuff. It's been I stayed on ADT after for 24 months. I did, and I wanted to ask the question: how long will it be before I get any results as far as no more hot flashes? Does my testosterone have to return to its previous level before I started this, which was 334? And before that, it was 526. So at 184, I think Peter's already answered the question that I probably won't see any results until 6 months down the road. I'm 3 months in now, and I probably won't see something until 6 months. Is that correct? That's pretty much what it is?
It
At least
varies
6
so
months.
much. It
Yeah.
varies an awful lot.
At this point, is 184 about normal as far as getting my testosterone back?
Pretty good.
It
Very
Pretty
good.
depends.
darn good.
Are you on Lupron?
I was on Lupron and I was on abiraterone.
Okay,
But
because different ADT drugs will have a different profile in terms of
yeah,
how
yeah,
quickly you
I figured that much.
respond.
Yeah. But I feel fine. I'm getting my energy back. I'm actually whipping people now on the pickleball court. Yeah, and I'm cycling up hills again. Pretty soon I'm going to move from my e-bike back to my regular bike. So I can definitely tell my strength is coming back. But
Yeah.
those darn hot flashes, man, they just won't leave me alone. So
Hey,
Well,
Cliff. Hey,
I'm gonna
Cliff.
count on Peter to guide me here. And he said 6 months. I'm gonna stick it out 6 months and see what the end's gonna be on that. But I'm so glad my PSA is still non-detectable, 0.014, and I was really concerned that because I was having the hot flashes that my testosterone wasn't coming back, but it's 184, so I'm happy. I'm somewhat happy.
Good.
oh, you sound great. Jim
Yeah.
Marshall, you got something about this?
Yeah, Cliff, Emily, I was on the ADT for 5 years. I am currently on the treatment holiday for 20 months. Testosterone just hit 232, and hot flashes I still have occasionally at night.
Okay. Yeah. Most of the time I have them at
So,
night too.
right.
Yeah. That's
And so
for
the
sure.
thing I do is to sleep with a sheet and a blanket, even though it's about 55 degrees in the house.
Me and you both, man.
And
Me and you both.
it makes a difference.
I
But,
carry a little portable fan everywhere I go,
oh,
just in
I
case. So
don't quite do that, but yep.
yeah, yeah.
John?
Okay, guys. Thanks for giving me the
Oh,
time to tell you where I am, and onward and upward, huh?
I think John has something to say to you. Hold on a second,
Well, I
Cliff.
just wanted to, Cliff, I wanted to chime in to those who said there's a lot of variability in this. Um, I've been fortunate in that I haven't had nearly as bad reactions. I certainly have had some hot flashes and some other things. The other thing I wanted to mention for the whole group is that oftentimes uh, ADT can really mess with your sex life.
Yeah.
And I actually heard prostate specialist from Utah several years ago talking about how for a number of his patients that daily 5 milligrams of Cialis, tadalafil, could be helpful. And I persuaded my urologist to he uh, um, uh, prescribed that for quote unquote urinary difficulties, but uh, that keeps I guess that keeps the price down, and it's been really helpful for me. And when we're going to have a senior sex morning or evening, I take an additional one, and because it sometimes clogs up my sinuses, I also take a ferritin at the same time to keep the sinuses unplugged. But it's really nice to be able to continue that kind of intimacy.
It's quite a common practice taking
Yeah, thank you very much for
it a
that
day.
that information, John.
All right,
Cliff,
folks, it's almost time. Anyone have any last words?
yeah, I've got a couple of things, John. First of all, and this is amazing because we've even finished on time today. So with everything going on, Cliff, first of all, it's amazing that you're back to 180 so quickly.
Hmm.
That's unusual. And, I think Steve Rule also said his testosterone was back up to 225. And it's astonishing that that these numbers are coming back so quickly
Yeah.
if you haven't been on Orgovyx. If you've been on Orgovyx, we're seeing it. But if you're not on Orgovyx, you guys are in the tail of the distribution. And so that's really great to hear. As far as how long it's going to be until the hot flashes start, to some extent, it is a function of the testosterone, and likely they'll, as your testosterone climbs, so you'll get fewer hot flashes.
Yeah.
But we can't really tell you. And normally, it can take twice as long as the time you've been on the ADT.
Yeah, I am.
So,
I'm at the very tail end of stopping the prednisone. So like I'm down to a half a pill every other day, and none on the weekend. So I'll be finished with that next week. So I don't know what effect that will have on me as well. Um, I hope
hopefully
my
none.
hands are doing better now, and everything is good.
The other thing I wanted to say to you, I put this in the chat window for everybody, is please join us tomorrow night. It's about 3 or 4 messages up in the chat window. I am, it might be a little late for some of you, but it will be recorded. But I'm interviewing my oldest buddy, closest buddy from the UK. It should be a riot because he's a riot. He's a retired cancer surgeon, mostly breast cancer and melanoma. Very funny guy. He writes his own lyrics to popular songs for medical skits, amongst other things. And he has gone around the country, he's gone around the world delivering this Art of the Breast presentation that he's going to give us an excerpt from. He's actually a world-renowned cancer surgeon because he did some of the very earliest work on sentinel nodes, and he's known for that sentinel node work. But he's also known for his Art of the Breast, which is the slides are quite funny and amusing. So it's at 7:30 Pacific because this is our joint presentation with the Marsh Theatre Company and UC in San Francisco. But if you're up at that time, if not, you'll find it on our blog or on Solo Arts Heal. And if you go to our Solo Arts Heal page, there's a link to the Marsh, and on that page you'll find 2 ways to join. It's free and drop-in. And that's all. Do we have anyone else who wanted to get anything in today, or say anything, or ask anything?
I did want to mention I went to the um, DLL3 site and the clinical trial, but they're looking for non-small cell lung cancer patients and not
No, they're not.
prostate cancer patients.
No, they're
That's what.
not. They're looking for the DLL3. They're looking for anybody. I've got it up here right in front of me. I know it says, if you go, it says brief summary, it says small cell lung cancer, but it's not just small cell lung cancer. This trial is open to a whole bunch of different cancers.
Okay. That seems like they misrepresented that in terms of.
Well, I don't want to argue with you about it, but we can tell you what Dr. Beltran presented, and this is the study she presented it from in 1 and 2, and what they're looking at is people, what they were looking at anyway for phase 1 and phase 2 was people who had it. So maybe we're wrong, but I would call
I'll
up
check.
and check with them,
Okay.
But I see what you're saying. I thought the same thing, and then I somewhere in the fine print I read that it was other it was neuroendocrine disease as well, solid tumor neuroendocrine disease.
I'll check into it. Thank you.
Patients with DLL3.
I was just writing to Len, but I think he's gone. Okay, everybody, have a good night. We'll see you next week.
Good
See you
meeting
next
you
Many
month.
guys.
thanks.
Good
Very
night. Thank
helpful.
you. Thanks, everybody.
Thank you, John.